for the invitation to this meeting. I'm delighted to participate. I wish I could participate in person, but hopefully for the future. And I'm going to talk to you today about pulmonary hypertension, diagnosis and management. And before I even start, just some of my disclosures, some of the companies involved in pulmonary hypertension that I've been involved in. But I thought I might start with this graph here, because I think it tells us a lot about pulmonary hypertension. And what it is it's data from the UK National Registry, and it shows the number of patients that they've been managing with pulmonary hypertension year on year over the past decade. And you can see that there's just each year increasing number of patients that are attending the clinic and being managed with pulmonary hypertension of all types. And really, this is what's happening out there in real life clinical practice. And it's because of increasing awareness, increasing diagnostic tools, but also because there are increasing therapeutic options for these patients. So it's really important that we do identify them. And what's interesting about pulmonary hypertension is that it has a mix of diseases within it. So there are over 30 causes of pulmonary hypertension described in 5 major groups that we'll discuss. But what's even more fascinating now, more recently, is the evidence that's emerging to suggest that the estimated prevalence of PH is 10% in those over 65 years of age. And I'll show you why that may indeed be the case, and why it means that we need to be increasingly vigilant, not only with picking up pulmonary hypertension, but also phenotyping it appropriately, so the appropriate therapies are used for our patients. Well, when it comes to trying to understand pulmonary hypertension better, the classification system is a good place to start. And the classification system has evolved over the past number of years. Back in 1998, there was the first sort of modern symposium on pulmonary hypertension. And you can see from the title of that meeting in Evian in France that it was primary pulmonary hypertension. And that actually was how it was classified at the time. There was primary, which was a rare disease that affected young women with a horrible prognosis. They died within 1 to 2 years from the time of diagnosis, really. And in 1998, there was very little in the line of therapy for them. As we'll see in a moment, we did have 1 or 2 treatment options for them, but really the prognosis and access to treatment was poor. Secondary pulmonary hypertension was everything else. But nowadays we have, and from the 2003 conference that was in Venice, we really clarified that classification a little bit further and broke it up into groups. And the reason why diseases are in different groups is because of the effect of treatment. So it's sort of a treatment-based classification, as we'll see in a moment. And the most recent meeting was in 2018 in Nice, and the recommendations from that meeting are still evolving and still are hopefully going to be part of the next guidelines on pulmonary hypertension that are expected out from the ERS and ESC next summer, or summer of 2022. So pulmonary hypertension really is now diagnosed by a mean pulmonary artery pressure greater than 20 millimeters of mercury. This is a change from the recommendations we've had in the past. We've dropped the mean pulmonary artery pressure, and it's a much more accurate depiction of abnormalities within the pulmonary circulation. And then we have 5 groups. And the first group is group 1. And we typically think of this as the old primary pulmonary hypertension, or what we now call idiopathic pulmonary arterial hypertension. But it also includes associated conditions. So a lot of connective tissue diseases, for example, are associated with the development of pulmonary arterial hypertension, most particularly scleroderma and systemic lupus erythematosus. But also you'll see it in liver disease, in HIV, and in congenital heart disease. Group 2, very common. This is left heart disease, left heart valvular heart disease, or systolic or diastolic dysfunction of the left heart. Most particularly, what we see is heart failure with preserved ejection fraction. And this can actually be quite difficult to distinguish from group 1 at times. And then there's group 3, and this is our patients with COPD, interstitial lung disease, and even those patients who don't have destructive lung diseases like that, people who have hypoxia, for example, obstructive sleep apnea, can develop a degree of pulmonary hypertension. And then group 4, a really important group to identify and often difficult to pick out, are those with chronic thromboembolic disease who've had a history of VTE, for example, in the past. And sometimes you won't even get that history from them. They'll turn up with evidence to suggest that they've had occult VTE episodes in the past and obliteration and occlusion of many of the segments in the pulmonary artery. And then finally, there's a miscellaneous group, and it's made up of things like sarcoidosis, for example, sickle cell disease, and so on. So those are kind of much more multifaceted aspects to their pulmonary hypertension. So as I mentioned, there's over 30 causes of pulmonary hypertension in these 5 groups. Group 1 and Group 4 are particularly important because we do have medical therapeutic options for them, and indeed for Group 4 we have surgical, as I'll show you. But this group here, Group 2 and Group 3, these are the groups that lead to this estimated prevalence of 10% of individuals over 65, because the prevalence of, for example, heart failure with a preserved ejection fraction is increasing, and so too is the secondary complication of that, which is the development of pulmonary hypertension. So how do we go about the diagnosis of pulmonary hypertension? Well, number one, you need suspicion. You have to have suspicion, and once suspicion is there, you'll start a clinical assessment. The history is very important, as I'll mention in a moment. Physical exam is really important. It's one of the really key areas still in clinical practice where you need to have your stethoscope, have a listen over the pulmonic region for a loud P2, have a look at the neck veins to see if there are signs of right heart failure and decompensation of that right ventricle. And looking at the legs for signs of edema and so on. You'll also find manifestations of other diseases that can cause pulmonary arterial hypertension, such as scleroderma with Raynaud's and telangiectasias, for example. There are a number of really key diagnostic tests. I mentioned here echo, VQ scan, chest X-ray and CT imaging, lung function testing, many bloods. But right heart catheterization is ultimately the most important test because it's the one that gives us the really accurate diagnosis of the presence of pulmonary hypertension. Well, once we've done these assessments, then we have the opportunity to do classification and to really phenotype our patients. And what's interesting about that, you can see here that when you do that, what you end up by finding is that Group 2 makes up the vast majority of the patients. Patients with left heart disease causing a back pressure into the lungs and increasing the pressure in the right ventricle. That's the commonest thing that we see. The second most common in many studies is, and many registries, is Group 5, depending where you're getting your data from. Group 3 also, lung disease is a very common thing that we see, and they can develop cor pulmonale or pulmonary hypertension secondary to lung disease. But then the Group 1 and Group 4, where treatment options are, they make up only about 5%. So it's really important that we take all of the causes of pulmonary hypertension and are very careful in phenotyping so that the 5% that need those medical therapies get them, and the other 95% of patients who don't require those medical therapies, which can be expensive and have side effects and so on, but they're not getting drugs that they will not benefit from. The symptoms of pulmonary hypertension, and this is a little image I got in Asia a number of years ago, and I like it because it shows us what patients get, and they're very non-specific. Breathlessness, some fatigue, hemoptysis, quite rare, but can be seen, and then obviously edema, signs of heart failure, and so on, and syncope is a bad prognostic indicator that we see in many patients. So the manifestations that you could see, these symptoms can be had in many other cardiopulmonary diseases. So the symptoms by themselves, unless you have suspicion and increased awareness, you may pass these and end up by having a patient with delayed diagnosis. Simple diagnostic tools, I think, are really important. ECG can show you right ventricular strain, right ventricular hypertrophy, for example. Very important to look at when a patient presents with unexplained dyspnea. The chest X-ray is really valuable as well. This is quite an extreme example here with really enlarged pulmonary arteries, but the lung fields are clear. And you can tell a lot from this. I can tell from the X-ray, for example, whether or not this is not left heart disease or whether it's not lung disease. I can't really distinguish between this and Group 1 and Group 4, for example, because I need to do a VQ scan and CT pulmonary angiogram imaging to get a better look at what the pulmonary vessels themselves look like. But it's a very valuable tool when someone presents with unexplained breathlessness. There are other tests that we do. Obviously, CT imaging can be really helpful. You can see in this patient here, this image, they've got an enormous right ventricle. And so this really does predict quite well that this patient has significant right ventricular afterload. And in fact, the prognosis here is really quite poor if the patient hasn't already been maximized in medical therapies. On the opposite side, you see VQ scanning. It's a mandatory test still to pick up chronic thromboembolic disease and outperforms CT pulmonary angiogram in ruling out patients with Group 4. And then lung function testing, very important for deciding how much lung disease is present, if it's sufficient to explain the degree of pulmonary hypertension, or whether in fact the patient has Group 1 or Group 4, for example. Diffusion capacity is becoming really important as a biomarker, and it can really identify patients with pulmonary hypertension, but those with a worse prognosis. But when all is said and done, the echocardiogram is probably, well, it's certainly the most important screening tool that we have for pulmonary hypertension. And when we do an echo, we actually look at two things. The first thing we look at is the peak tricuspid regurgitant velocity. We measure the right ventricular systolic pressure, the RVSP. But sometimes that can give us numbers that don't fit with the whole picture. So we take that number, but we also add it to the presence or absence of echocardiographic pH signs. And those signs that we look for include signs in the ventricle. So, for example, an enlarged ventricle or a D-shaped septum. We look at the pulmonary artery and we look at the Doppler acceleration time in the right ventricular outflow tract. We also look at the pulmonary artery size. And then we look at the inferior vena cava and the right atrium and look for signs there to suggest the patient may have pulmonary hypertension. And then we take the combination of these two to come up ultimately with an echocardiographic probability of pH. So when we do an echo, we're looking for the probability rather than the absolute of whether a person has pulmonary hypertension or not. When it comes to looking for an absolute, most important test is right heart catheterization. And at right heart catheterization, we can confirm pulmonary hypertension by finding a mean pulmonary artery pressure greater than or equal to 20 millimeters of mercury. We can confirm that it's group 1 PAH, for example, by showing that the pulmonary arterial wedge pressure is normal. And if we look here, here's just a schema of a patient of a right heart catheterization. It allows us to measure the right atrium, which is an important measure of right ventricular function. We measure the pressures within the right ventricle. We then go out into the pulmonary artery, and ultimately we go out deep into the pulmonary artery and blow up the balloon and have a look at what the estimated pressure in the left atrium is, the pulmonary arterial wedge pressure. And you can see this nice tracing across. And that's what we do every time we do a right heart catheterization to tell us whether the patient has what we would describe as precapillary or postcapillary pulmonary hypertension, depending on the pressures in the left atrium, which we'll come to in a moment. So these are the new hemodynamic definitions, and I have them kind of bolded in red here. So we now say that pulmonary hypertension is present when the mean pulmonary arterial pressure is greater than or equal to 20. We say that it's precapillary when you have a normal pulmonary arterial wedge pressure and the pulmonary vascular resistance is elevated. It's postcapillary if the wedge pressure is high. And then we can break that down a little bit further and say, well, it's isolated postcapillary if the pulmonary vascular resistance is low, but it's a combined postcapillary precapillary picture if the wedge pressure is high, but also the pulmonary vascular resistance is high. So that's kind of the new way that we're approaching the hemodynamic definition of pulmonary hypertension. And what's really important is cardiac output measurement is really mandatory in right heart catheterization, so it allows us to measure the pulmonary vascular resistance. So let's have a look at some of the different forms of pulmonary hypertension. If we were to zoom in here for a moment about group 2, left heart disease. What we do when we see a patient and we're wondering about left heart disease is we come up with probabilities. And somebody who has a high probability of having left heart disease would be somebody who's older in age, who has at least 2 other risk factors for left heart disease, such as obesity, hypertension, diabetes, and so on. If they have atrial fibrillation, it's really quite probable that they have left heart disease rather than pure precapillary disease. We look at echocardiography, we may do a cardiac MR, but we're really looking for what's the overall likelihood that this patient has left heart disease versus isolated group 1. And we then come up when we see someone who's high probability, we just go ahead and treat their left heart disease. If they're intermediate probability, for example, we'll then have a look at the echo or the MRI and see if there's much to suggest right ventricular abnormalities. If there is, then we do a right heart cath and dig that a little bit deeper. If there is none, well, we'll consider getting right heart cath, depending on really how symptomatic they are and whether really this still remains to any degree a diagnostic dilemma. So probability is really important when it looks to the left heart. Well, what about group 3, lung disease? Really common manifestation is pulmonary hypertension in those patients. And this, the latest guidelines would suggest that what we do is we look at the physiological severity of their underlying lung disease using pulmonary function testing, and the morphological severity looking at imaging. And those who have more limited disease, so they don't have that much obstruction, don't have that much restriction, mild parenchymal changes, chances are those patients are more likely to be group 1 than group 3. If it's much more severe, then they have group 3 pulmonary hypertension. And then what you want to do is worry about what's the severity of it. We now are moving more and more towards looking at the pulmonary vascular resistance to decide on how severe it is or not. If they have severe pulmonary hypertension, you may consider some of those for individualized therapies for their pulmonary hypertension, depending on their overall comorbidities and so on. But if it's mild to moderate, there's really no evidence that treating patients with lung disease with mild to moderate pulmonary hypertension really makes a difference. But things are changing. Many of you will have seen this paper in the New England Journal last year that showed that inhaled treprostinil could be beneficial in pulmonary hypertension due to interstitial lung disease. And in fact, as a result of this paper and the evidence, the FDA approved treprostinil for interstitial lung disease associated pulmonary hypertension. And what they based that on was this data to show an improvement in 6-minute walk distance in those who had interstitial lung disease who had inhaled therapy. So that's the first time we've had an approved drug for somebody with group 3 pulmonary hypertension. And so who knows what the future may hold in that as we now explore that even further. Very important just to mention group 4, venous thromboembolism, chronic thromboembolic disease. These are patients that we need to identify with VQ scanning. Some of those patients respond really very well when they have proximal disease to surgery, a pulmonary thromboendarterectomy. The ones that are a little bit more distal might nowadays respond to balloon pulmonary angioplasty, and more distal disease, we still use the medical therapies that we use in group 1. We use now in group 4 as well. But finally, just to mention group 1, and group 1 is PAH. And PAH now has a very important 40-year anniversary this year and last year. It was the first lung transplant for pulmonary arterial hypertension it was in 1981 and was for patients with pulmonary arterial hypertension. But the Nobel Prize then went for the discovery of prostacyclin in 1982. And so it's 40 years since we've had those developments that have really impacted upon patients with pulmonary hypertension. We've had 2 other pathways that we now treat with pulmonary hypertension. We treat the endothelin pathway. We have drugs ambrisentan, bosentan, and macitentan. And these drugs antagonize or block the endothelin A and B receptors, which are important in mitigating the vasoconstrictive and proliferative effects of endothelin. And in 2005, we had the development down through the nitric oxide pathway, where we had sildenafil and then tadalafil as phosphodiesterase type 5 inhibitors were developed for pulmonary hypertension. And more recently, riociguat, which is a soluble guanylate cyclase agonist, which is used in patients with PAH and indeed group 4 chronic thromboembolic disease. And then more recently, while we've had parenteral prostacyclins and inhaled prostacyclins for many years, more recently we now have an oral prostacyclin receptor agonist, selexipag, to target this prostacyclin pathway. So we've 3 pathways that we can target for patients with PAH. The AMBITION trial is the most important single trial I think that we've had in pulmonary hypertension for many years, because what it showed us was the way to approach treatment. And what it taught us was that combination therapy with a PDE5 inhibitor and endothelin receptor antagonist outperform pooled monotherapy or monotherapy with tadalafil, which was the PDE5 inhibitor, and ambrisentan, which was the endothelin receptor antagonist in that study. So we now start all patients upfront on double combination therapy to all comers. Sometimes we'll do triple if they're sick enough. And indeed, how we make that decision is a thing called risk stratification. And we do a very non-invasive approach to risk stratification. We decide if a patient has low risk for mortality in 1 year, intermediate or high, and we base that on their functional class, their 6-minute walk distance, or indeed their biomarker, BNP. And we will categorize them into low, intermediate, high, depending on the results of those studies. And there's a lot of move now to maybe do that into intermediate low and intermediate high to get a more granular picture about risk stratification. So ultimately what happens is when patients are initially seen, the majority of patients are intermediate or intermediate low. After you've treated them, you get a bit of a change, but still you have a lot of patients who remain high risk and intermediate high risk. And so in that time period between first visit and first follow-up visit, we have an opportunity to refine treatments. So we go with initial combination therapy, oral, for the milder patients. We use parenteral therapies for the more sick patients. And then if we see them back and they haven't improved, we go to sequential therapies, either adding in a parenteral prostacyclin here, or maybe an oral prostacyclin agonist like selexipag here. But it really depends between the first visit and the second visit whether you've had a robust response to treatment. So risk stratification now is the name of the game when it comes to deciding on treatment and escalating treatment in PAH. Well, what about the future? Well, a lot of targets in pulmonary hypertension that we could go after. We know there's proliferation of smooth muscle cells. We know there's a lot of action going on in endothelial cells, leading to growth and proliferation. We know that there's migration of fibroblasts and pericytes and so on to give this very proliferative picture that we see in the distal blood vessels in patients with PAH. There's a lot of excitement now that maybe we might have discovered a fourth pathway. And we've known for the last 20 years that there's a gene responsible for heritable forms of PAH. And that gene is bone morphogenetic receptor, protein receptor 2, BMPR2. And that receptor is involved in inhibiting, to a degree, growth and proliferation of blood vessels, and it's a TGF-beta type receptor. Well, trying to reset the balance by having any deficit in BMPR2 has been a goal of therapeutic endeavor for the last number of years. And a new drug, sotatercept, is an activin binder. And what it does is it resets that balance to a degree where sotatercept binds the activin, which is increasingly active in the setting where you have BMPR2 knockout. And so overall, sotatercept, in a recent study, and many of you will have seen it in the New England Journal last year, it reached its primary endpoint, improvement in pulmonary vascular resistance, and indeed 6-minute walk distance was improved by 24 weeks in patients who were on this, and they were on background therapy already. So really encouraging. And one of the pathway that's important is PDGF, or platelet-derived growth factor. We've known from a study in the past that imatinib, which is a tyrosine kinase inhibitor involved in that PDGF pathway, that it was studied in PAH in the past, and in fact, it reached its primary endpoint by showing improvements in exercise capacity and hemodynamics, but it was withdrawn because of the amount of side effects that the patients were getting. It's now being developed in an inhaled route. There's a lot of excitement that perhaps the dosing that we might get by inhaled might mitigate some of the side effects we were getting by the more systemic absorption of the drug. So we'll see. So two pathways there that are really moving along really quite quickly in clinical trials. Well, let me finish with a little thought here. I told you that the first lung transplant was 40 years ago. It was a heart-lung transplant for a patient with idiopathic pulmonary arterial hypertension. And indeed, she wrote this book, I'll Take Tomorrow, the courageous woman who dared subject herself to a medical experiment, the first successful heart-lung transplant. And unfortunately, she didn't live that long with the heart-lung transplant. She was the first. But her words, I'll Take Tomorrow, I think resonate with all patients with PAH as they struggle to get extra days from this disease. But there's no doubt that the improvements we've made over the past few years are really encouraging. And the new therapies I just mentioned there add to that encouragement. So let me finish by saying that when it comes to pulmonary hypertension diagnosis and management, the incidence and prevalence of PAH is becoming more common in routine clinical practice. So awareness and suspicion are crucial to getting an early diagnosis. Secondly, a careful diagnostic workup is key to making the correct diagnosis before deciding on treatment. Phenotyping is key. Thirdly, effective treatment options are available after you've done risk stratification for patients with group 1 PAH or group 4 chronic thromboembolic disease, and they're emerging too for group 3, as we heard with the inhaled treprostinil. So new treatment options are also very promising. But my fourth point would be the lung transplant remains the only cure for severe PAH, so we still have a lot of work to do.